Hello everybody, it's Martin Kiernan here again, and today we're going to be talking to Dr Valeria Fabre, who's Associate Professor of Medicine at Johns Hopkins, where her area of expertise is infectious diseases. She's Associate Medical Director of the Antimicrobial Stewardship Program and also an Associate Hospital Epidemiologist there. But the reason we're going to be talking to her today is she's just been lead author of a paper published in Infection Control and Hospital Epidemiology on a practical guide to diagnostic stewardship. So that's what we're talking to her about today. So welcome, Valeria, and thank you very much for sparing me the time.
Oh, thank you. My pleasure.
Okay, so diagnostic stewardship, to me, when I started out in infection prevention, it was always something that the laboratory did. They tried to get the best out of the specimen that we sent them. But of course, now we're getting to the fact that there's far more to it. So can I ask you to talk about what's the background to this paper and why you felt at SHEA that practical guidelines were actually required?
Yes, absolutely. So that is true. Most might view diagnostic stewardship as something that belongs to the laboratory, and obviously it has addressed laboratory tests within infectious diseases, but also in other areas such as a good use of the dimer or good use of other common tests that we order in patients. And we realized that actually, diagnostic stewardship can be performed by people outside of the lab, both by, what we call prescribers, so, physicians and advanced practice practitioners, nurses, and really anyone who's at the bedside caring for patients. And so, a big area of interest to me is antibiotic stewardship. And several years ago, I was working on an initiative at my hospital to improve the utilization of urine cultures, because that was one of the main drivers of inappropriate antibiotic use at my institution, and that happens to be the case in many other institutions in the United States and elsewhere. And so we realized that most of those decisions were happening at the bedside, many times not necessarily involving the physicians. Many other times the physicians were involved, but we realized that there was really a big need to improve how we utilize common microbiologic cultures. And so we realized that there were opportunities not only at the time of reviewing the indication for a culture, but also opportunities to improve how clinicians interpret a result. We know that many of our colleagues who are not trained in infectious diseases struggle with interpreting a positive of culture and understanding what's the difference between different levels of growth and what's the difference between colonization or contamination and a true infection. So we started to work on all these different steps within what we call the diagnostic pathway of a test, and realized that there were so many, steps in this pathway that we need to integrate the bedside providers and laboratory and get these different groups, closer and working together on improving some of these practices.
It's interesting you say that the nurses were making the decision. So the nurses would send a culture without necessarily referring to a physician. So that would actually be pretty much similar here in the UK. And of course, interestingly, I was out of the country last weekend and I saw a poster from a hospital in the UK that I used to work in, showing that the nurses were generating the specimens. The clinical information provided to the lab was almost always inadequate. And it was just going down as things like urine. They wouldn't even specify what the specimen was. And that makes it very difficult, doesn't it, for the lab to work with, because they only get what they get. And there used to be this saying, rubbish in, rubbish out. If that's all you got to work with and you haven't got any information, how on earth do they interpret what they're seeing? So was that the similar sort of picture that you were seeing?
Yes, exactly. That was exactly right. And as I got to work in diagnostic stewardship, for example, an area of interest to me is diagnostic stewardship around blood cultures. And there are lots of improvements, for the physicians who are the ones that almost always make the decision to order a blood culture. And depending on the unit, they might be the ones involved in collecting the blood cultures.
Mm-hmm.
And so some of the aspects that I got to work with them on were obviously to improve indications for blood cultures, but also I addressed many misconceptions that I was not aware that existed, among my non-ID colleagues, right? And so, exactly.
So what misconceptions were you able to address then?
Well, for example, we did many focus groups, and we found that some of our colleagues in the intensive care unit were not aware of the importance of obtaining two sets for adult patients. And they, perceived that not knowing the importance of the two sets on the sensitivity of blood cultures, many times they were allowing or going for one set because they know it's painful for patients. Many of ICU patients, it's hard to get a blood culture because they are very edematous, and it's hard to find that site for peripheral venipuncture. And so those were some of the examples of some of the misconceptions that they had.
Okay, that's interesting. I mean, part of the problem I find in my own hospital, I used to be quite concerned about the number of contaminated blood cultures, as a lot of them were coming from the emergency room, where I don't think people would necessarily taking a lot of care because they weren't ever going to see the result anyway, or the patient, again, it was just, let's get a blood culture. And everything I tried to get them to think, let's do a good blood culture here, and so that somebody, at least when they see the result, they're working with something that's going to be useful rather than just a staff or where did we go with this one? That was a key issue, really. Are you having the same sort of issues there, where people who take the blood culture aren't necessarily the people who then will be treating the patient and interpreting it?
Yes, absolutely. Absolutely. We are a large academic institution, so there's always someone who's leaving the door, and a new team is coming through the door. So that's always a challenge. And yes, so I think that's a common problem, in most institutions.
So how can patients be harmed then by poor diagnostic stewardship? What sort of damage can be done? Are we talking about misdiagnosis here now, overdiagnosis, or
yeah, absolutely,
or just misinterpretation?
Exactly. So it depends on the type of test that we are talking about. Some of the things that we discussed so far regarding urine cultures and blood cultures have to do with picking up false positives and treating patients with antibiotics for false positive results, which I'm sure the audience is very well acquainted what are the issues with inappropriate antibiotic use. Not only in terms of resistance, but also in terms of adverse events for patients. And it could also go with, as you were saying, misdiagnosis, right? So, for example, we did a lot of education around fungal markers because there was a lot of misunderstanding of what was the utility of the different fungal markers like beta-glucan and galactomannan in ruling out invasive fungal infections. And not knowing, when it's the right time or when it helps you. You might be thinking that there's no fungal infection because the fungal markers are negative, when, we know that these fungal markers are not going to be positive in certain fungal infections. So it's not always about doing less, but it's more focused on doing it when it's right? Doing it when it's right and in the right way. Exactly.
Yeah. Okay. I mean, do you have the same sort of issue that many countries also have with people would get treated for asymptomatic bacteriuria just because the pathology result has grown some microorganisms, but actually the patient may not have much in the way of signs of infection?
Absolutely. So we have pushed very hard on this aspect of, if you are looking at a positive urine culture result, the reflex should be to go back to the bedside and ask, try to collect that history from the patient or a family member if the patient is not able to speak, as to, what were the symptoms that might have led to that urine culture or brought the patient. As you were saying, many times for example, the urine culture, since we are focusing on that, get ordered in the emergency room, and there might not be a necessary, an appropriate reason. And if you don't go back to, and ask, you would be just treating positive results for a patient that did not need a urine culture.
And it can even be the technique of actually taking the specimen that can have really messed things up as well. You can contaminate a urine as much as you can contaminate a blood culture, I suppose. And that's the issue as well, isn't it?
Yes, absolutely.
Can I ask you about wound swabs? Do you feel that it's necessary to absolutely describe the type of wound, whether it being a decubitus ulcer or a surgical wound or a venous leg ulcer or something like that? Do you think that makes much difference to the interpretation now? Because I know in my early days, the laboratory would be trying to interpret what potential pathogens they might see. And when they had certain clinical information, they would maybe look for slightly different organisms, like some more obscure streptococci in the case of venous leg ulcers. Would that be the same, or do you think diagnostics have moved on so that you would pick out the genuine pathogens from any wound swab, regardless of the clinical information?
Yeah, I think I have to say that I'm very lucky to work at a place with a very strong microbiology laboratory. So most of our methods are very sensitive, and it's quite robust. And again, it's a very large hospital, so we couldn't be communicating and telephone for each case.
Mm-hmm.
Obviously, when we put an order for a wound culture that gets processed in the microlab, they will see some clinical information about the patient, but there won't be a communication specifically addressing, can you look for, this particular pathogen? We do that when we suspect, for example, if the patient was getting antibiotics and we wanted the lab to hold maybe a culture a little bit longer for an unusual pathogen.
Uh-huh.
In those specific circumstances, yes, but not for most of the, usual suspected bacterial infections. Yeah.
Okay, so what strategies then are you recommending that could actually improve things? What can we do to help people produce a better specimen, or only take a more appropriate specimen, so that we're not doing unnecessary tests, which can result in patient harm, but actually also cost money and produce challenges for antimicrobial resistance as well?
In our experience, really, it helps to educate around the need for diagnostic stewardship. So there's the perception that there's no harm associated with, right, for example, getting cultures or ordering a test. And so we have to work on that. And there's also the perception that maybe if you don't do it, you might be missing something. And so there's also the need about educating about, how to use the test, right?
Yeah.
As we were discussing, when you are assuming that, because you did it, a negative result, the patient doesn't have the infection, as you were saying, for example, in the case of blood cultures, a negative result, if you just got one set, to me, that's not reassuring.
Yeah.
Exactly.
Yeah.
So making sure they understand, when they should feel appropriately reassured. So knowing how to use the test is extremely important. Now, whether you do that, by developing, I think that's part of the challenge too, how to communicate all this information to busy healthcare providers, right?
Yeah.
And so I think that's where each institution has to work based on, their local resources, how to best get to the frontline providers. So if it's heavily EMR based, there's lots of tools that you can implement, such as, best practice alerts or, guidance on the EMR. If it's, more paper based, then I think there's many strategies, but it will depend on where you're working and who's your audience.
Yeah, I mean, because
not everyone wants to see.
No, well, that's true.
See the information the same way.
No,
right?
absolutely. No, right. That's absolutely right. I was wondering if electronic ordering systems for specimens, you could build in nudges and questions to make sure people are thinking about it all the way through the process, or can they just order a specimen and it gets taken regardless? Can you build nudges and checks and balances into those sort of systems?
Yes, absolutely. And I think a lot of people have tried that and it has worked. I think, again, You have to kind of like know your crew, right? Some people like to be told what to do. Some people get very upset, if you take a restrictive
Yeah.
approach. So and that's why it's important to get a good balance as to, what's a strategy that will work for most people. Yes, EMR tools have been very helpful in most places to help with diagnostic stewardship.
And what about training for people? Because people maybe will get trained in how to take a blood culture, and then after a while they slip into old habits and they're more interested in getting it done as quickly as possible. Is there any system for checking competence of people taking blood cultures, or do you have teams of people maybe? Because I know we've had some success in the UK where there are designated staff during the day. They will be the ones actually taking the blood cultures, and therefore you find these specially trained phlebotomists get far less in the way of contaminants than people who are not well trained.
Yes, absolutely. It's it's been shown that if you have a dedicated team, your chances of getting a false positive results are much, much, much lower than, if people without those skills are getting the blood cultures. And so there's that. There's obviously lots of back to the basics kind of elements such as obviously hand hygiene and good skin antisepsis. That if you don't have a phlebotomy team or like a trained team, you can go, through training that of basic practices that, would be helpful.
I mean, are there any papers showing that feedback of contamination rates to departments actually improves practice?
Yes, absolutely. I will say that most of the literature evaluates a bundle, right? So it's hard to find, a paper that only did one thing, right? So it's usually a couple of things. And so sometimes it's hard to, tease out exactly to which one of them the effectiveness was attributed to. But yes, there's lots of literature regarding where are some of these, what are the elements that need to be in these prevention bundles or, contamination reducing bundles, I should say. And feedback is one of them.
Yeah, I was wondering if you were regularly monitoring, say, the emergency rooms contamination rate, and then suddenly it goes up by 2-3 times, and then you go and find you've got a load of locum or agency staff in and who haven't been trained, and that can throw things completely out.
Yes, absolutely. So until recently, the national benchmark for blood culture contamination in the US was equal or below 3%. And at our hospital, we had an internal benchmark of equal or less than 1%. And very recently, CLSI has updated their recommendations and has lowered the benchmark to equal or less than 1%.
Right.
So for a very long time, we've been measuring blood culture contamination, not only in the emergency room, but in all inpatient units. And we feedback this data back to unit leadership, including obviously nursing and physician leadership. And everyone is very well aware of where they are. And if obviously they are above the target, then we reach out to see, what are some of the struggles, what are some of the issues. And then specifically for phlebotomy, so for this group of people who are trained, and that's the only thing they do, many places many units are doing individual level feedback.
Oh, wow, okay.
Right?
Yeah.
So exactly to understand, and so there's lots of things that can be done. Obviously, what I said, we can only do it because we have, the resources, like someone is pulling the data for us, and we can share the data. And so exactly.
I mean, and finally, I'm not so worried about the financial cost of the institution if it's the right thing, but actually there are cost implications of inappropriate specimens. And then the knock-on effect on the patients. Has anyone done any work on the cost-effectiveness of diagnostic stewardship? And therefore, say, for example, you wanted to bring in a bundle and you wanted to bring in a blood culture collection pack, which might cost a few more dollars to actually implement the pack. but you would be able to make savings. Would you be able to demonstrate savings, or are there any studies demonstrating savings by implementing this sort of program?
Yeah, absolutely. So the paper guidance that you mentioned at the beginning of this call is actually the first one of a series. So yes, so there will be other ones that will be coming specifically addressing, for example, the impact of diagnostic stewardship in HAIs, in antibiotic use. And so probably you will see that type of data summarized in the topic specific papers that are going to come out. Mm-hmm. I can tell you that, yes, there is already data, again, depending on for example, if you're looking for blood culture contamination specific ones, that data exists. It might not be there for things that are less usual, less common. Mm. I have to be honest that we didn't want to put a lot of emphasis on cost reduction when we wrote the paper, because we didn't want people to feel that, diagnostic stewardship, it's about cost reduction. We really wanted to, emphasize that it's about patient outcomes. Sure. And patient safety, with obviously this secondary advantage of the more appropriate you use your hospital resources, right? Yeah. The more cost-effective care becomes. Yeah,
I was more thinking of trying to make a case for investment in a change in practice. Would that be necessary? Yes. Would that help with that? That's what I was really thinking. So
yes, absolutely, and I think that's important. I just wanted to make the comment of why maybe there's not a lot of cost mentioned in that particular paper, but absolutely agree that exactly in order for you to build, a program or, implement initiatives, it has to make sense.
Okay. That's wonderful. Well, thank you very much. I've really enjoyed reading the paper. As it says in the title, it's a very practical guide. There's a lot of advice on strategies you can use, like nudging, like the form of prescribing you do, like the training you might need to do. And it's a very nicely accessible paper that will be applicable to hospitals all around the world, I think, because everybody has exactly the same sort of problems. So I really appreciate you spending a bit of time with me just to have a little chat about this important issue.
Great. Thank you for having me in your program.
Okay. And everybody, I'll see you on the next episode of Infection Control Matters. Thanks for joining.